Thank you, Marcelo. Thank you very much for the invitation, and thanks to those of you we haven't lost to the golf course yet here. Um, so this is a very broad topic. I have worked with a number of companies, but I have no direct financial relationship with regard to any of these embolic products that we're going to talk about, but we will be talking about off-label use of some of these devices. And what's really interesting is to look at the proliferation of embolization agents that has occurred, and ever since Charles Dotter reported the first embolization procedure in the literature in 1972 when he embolized the GI bleeder with autologous clot. And now we have just an incredible array of agents at our disposal. And this is not an exhaustive list, this is just sort of the basics. You can see we have gel foam and thrombin, and we have all different kinds of coils. We have vascular plugs and occluders. We have stent grafts that can be used as embolic agents. We have glue, onyx, alcohol, sotradecol, and then a whole host of particulate agents with technology that's very rapidly evolving in that area, and that could be an hour-long lecture unto itself. But anyway, so it's great that we have all these at our disposal now at this point in time, and this is just one manufacturer's range of products in calibrated microspheres, and these spheres for this particular company are now available in sizes from 40 microns all the way up to 1,300 micron size, which is just a huge size range of particles. And so we have just a great amount of materials at our disposal. This is an algorithm that was presented at RSNA this last year by Drs. Funaki, Ray, and Lebarsky, and actually it's a nice sort of decision tree, very basic decision tree here. And you can see that what they do here is they talk first about the size vessel that will be you're targeting, and then look at either permanent or temporary embolization. And so temporary embolization and trauma, we're talking about gel foam. Permanent embolization in large vessels, we're looking at coils and amplats or occluders and things like that. And then over on the small vessel side, sort of making choices depending on whether or not you want to maintain tissue viability or whether you're actually trying to cause tissue death by your embolization procedure. So obviously the indication, and clearly the therapeutic indication is driving your choice of embolic agent, not only the therapeutic indication, but the size of the vessel and whether or not you need to get back into that territory or not. So I think what I'd like to do just for the next few minutes is examine some of these critical issues that all of us think about every time we're going to do an embolization procedure. And some of these I'm going to talk about in a little bit more detail, but anatomy of the situation is really most critical. What's the vessel size? What's the length of the target? Are there branches in the area that can be sacrificed? What is the access to the target area? Can we get a microcatheter, or can we get a stable catheter system to our target or not? Some cases that's very difficult or impossible. What's the flow like in the target vessel? Is there shunting? Is it high flow? Matt Johnson's going to talk about that in a few minutes in a little more detail. What's the urgency of the procedure? Do we have all kinds of time to do an elegant microcoil embolization, or do we have to just get in there and stop someone from bleeding to death? Do we want this to be a permanent occlusion, or do we want these vessels to open back up again? What's the risk if the embolic agent goes where we don't want it to go? Is it going to cause a big problem? In some cases, it's not going to cause a big problem. In some cases, it's going to cause a stroke or something equally catastrophic. So we have to take that into account. Do we want to cause tissue death? Are we embolizing a tumor? Do we need to get back in there for repeat treatment? And then, of course, we have to consider in this day and age the cost of all these different agents and what the reimbursement is like, and that's a factor that's becoming more and more important. So let's just talk a little bit about anatomy of each of these situations, and of course these are all generalizations, but as all of you know, this is really an inexact science. When you're trying to size a coil, for example, for a specific situation, you have to take into account all different kinds of things, the flow effects, the unpredictable nature of how coils will form in different situations, whether or not the vessel is in spasm, how precise do I have to be about where this coil ends up. If it migrates a little bit distally, is it going to be a big deal, or is that going to cause a big problem? Are there side branches I have to worry about? It's really critical in all these situations to have stable access, and so sometimes you'll have a coaxial system, sometimes you'll have a triaxial system to be able to have a stable platform to do your embolization procedure. And really what I was telling my fellows is prepare for the unexpected and basically think to yourself, for example, if you're trying to pick a coil size, what's going to happen if I pick a coil that's too small, and what's going to happen if I pick a coil that's too big, and then choose the lesser of those two evils. And I think that's a reasonable way to go. And also remember, it's always the last coil that gets you in trouble. This is just an example of a case where the anatomy really dictates the device that's used. So this is a 78-year-old who came into his primary care doctor with indigestion, and he actually did a physical exam and felt the mass in the right upper quadrant here. And on CT scan, you can see that he's got this very large 6-centimeter aneurysm that appears to be arising immediately adjacent to the SMA. And so we look at him. This is a SMA angiogram, and you can see here, this is the pancreatic duodenal arcade, which is hypertrophied with retrograde flow all the way back to the origin of the celiac artery. So he's got either celiac occlusion or arcuate ligament compression. This is the branch that's supplying the large aneurysm or pseudoaneurysm here, and then there are branches going to bowel arising immediately adjacent to this vessel, which really can't be sacrificed. So we can't put a covered stent in here and cover this up without causing ischemia. So this is a very unique situation, and you can see here when we get a microcatheter into this vessel how short of a landing zone here we have to try to get this accomplished. And we actually initially, probably foolishly, tried to put a couple detachable coils in here. We could not get anything in this very, very short area to form and to sit in that area of a coil. So the answer is probably obvious to all of you, but basically the ideal agent here is an Amplatzer device. This is one of the older Amplatzers that is the shortest actual total length of the device, which we needed here. And you can see we deployed that very nicely. You can, for those of you who used it, you know that you can deploy this and make sure you like the way it's deployed before you release it. And after we deployed it, as we were getting ready to maybe pack some microcoils on the side here, it completely thrombosed and it looked good. And this is the follow-up CT scan at 2 months with the aneurysm completely thrombosed. So the anatomy of that situation completely dictated the agent that we needed to use. AV shunting and high flow situations, Matt's going to talk about a little bit more, and so I won't dwell on it too much, but really these are very challenging and higher risk situations, because in high flow and shunting situations, coils don't form the way they normally would. You really need to try to get control on the other side of the venous side of an AV fistula, for example, if at all possible, to control those situations. You have to adjust particle size if you're doing particulate embolization in the setting of AV shunting. And obviously it's nice to be able to use detachable devices in those situations to hope to make sure that things are going to stay put, although even though it looks like it's going to stay put when it's attached, doesn't mean it's necessarily going to stay put when it's detached. And we learned that the hard way. This is an example here of a patient with a bruit in his abdomen. He's asymptomatic, but it found a bruit, and you can see he's got this markedly enlarged tortuous renal artery on the right, and he's got a big renal artery aneurysm here with a rapid filling of the renal vein. So he's got an AV fistula with an associated renal artery aneurysm. And here's the angiogram. You can see that we've got some challenges here, again, with regard to the anatomy and the access with this very tortuous artery and the shunting going into this markedly enlarged renal vein. So what our goals here that we want to do is we want to preserve the renal parenchyma as much as possible. We want to avoid non-target embolization through the fistula, so we don't have to go fishing in the lungs for coils. And we really want to consider cost here as well, because if we need to pack that entire big saccular aneurysm with coils, that's going to take a lot of coils. It's going to be expensive. And I think it's also higher risk because it's more manipulation inside the aneurysm sac. It's higher risk of rupture of the aneurysm, and probably also higher risk of infection with multiple more foreign bodies being put into the patient. So in this case, again, getting stable access is key. We have a guiding catheter all the way out here. We have a glide catheter out into the distal renal artery, and the anatomy was very fortuitous here. There's very little renal parenchyma that's being supplied by this branch, and so we can actually occlude the fistula and occlude the aneurysm by occluding the influence. So here we used a large coda balloon to occlude the renal vein simultaneously while we're doing the embolization procedure, and we're able to occlude this